we'll go to the last present of the day, Dr. Ravinder Singh from SMS Middle College, Jaipur.
Good afternoon, everyone, respected chairpersons and teachers. First, I would like to thank organizers for giving me this opportunity to present the CD. And this patient, Mr. Kaluram, 55-year-old male, who was a smoker with no history of any hypertension, diabetes, presented with angina on exertion, class 3, despite optimal medical therapy, and he was taken for an angiogram. Angiogram showed presence of single vessel disease, LAD. There was 85 to 90% lesion in the proximal LAD, and similarly 85 to 90% lesion in the distal LAD. This patient was taken for a planned PCI, right radial axis was taken, and EBU 4.0 catheter was taken. The left coronary ostium was hooked with the catheter. So here we can see, this is the RAO caudal view. Here we can see lesion is present in the proximal LAD. And immediately upon hooking the artery, what I noticed was that his heart rate increased from 90 to 140. However, his blood pressure was stable and patient did not complain of any chest pain. And another view was taken to profile the left LAD. So this was another view, and what we noticed was that left LAD had completely gone into spasm. And what we could do at this point was I took a Cougar XT wire and passed it immediately across the lesion in LAD. However, the patient's blood pressure came from 140 to 100 to 90 to 80, and another shot showed us that the left LCX also went into spasm with all its major branches. Now, patient started developing hypertension, blood pressure came to 50, and he was started on inotropes. And before we could think about the cause, we noticed that the left main coronary ostium had also gone into spasm. So here we could see the entire left coronary system was into spasm. Patient developed a VTVF, he was given a defib, and the race started, CPR was started, patient was immediately intubated, and he was done ambu bag. At this point, we divided our team into two. One was looking after the CPR, and another team we were trying to find out the cause of spasm and how to deal with it. So we had two options. One was to either put an IABP or to deal with the complication. So the left groin was being prepared. At this time, we gave intracoronary nitroglycerin 200 micrograms. However, nothing happened. There was no coronary dilatation. And finally, we all reached a consensus that probably the left main coronary ostium has gone into spasm or there is a dissection. So we decided to stent the left main ostium with the 4x12 driver balloon. And as we were trying to position the balloon, what we noticed that left main had started opening up. The pressure had started rising up. The blood pressure had came to 60. However, patient was on ambu bag and respiratory support was being provided. Slowly we noticed that the left LCX and its branches had started opening up, and this was the time when we again gave a bolus of intracoronary NTG 200 micrograms, because in the previous position, the entire left coronary system was in spasm. So whatever intracoronary NTG we were trying to give was going into the systemic circulation and nothing was entering into the coronaries. So slowly we noticed that the LCX had started opening up, the left main had started opening up, and we abandoned the idea of doing a left main ostial stenting. Finally, 3x24 mm bare metal stent was placed in the proximal LAD. The blood pressure had started rising up, blood pressure had come to 110, however the patient was still intubated, but he started struggling with the endotracheal tube, and here the patient also had an insignificant lesion in the LCX. There was a lesion which was present in the distal LAD. POBA was done to the distal LAD lesion. This was the final shot, and at this point what we noticed that the blood pressure was stabilized. However, he was on inotropes. He was on respiratory support, and patient was the left coronary, left main and LCX were normal, and patient was shifted to the cardiac ICU. So the aim of presenting this presentation is that the total spasm of the left coronary system is rare. We can see the presence of spasm in an artery which has got disease. Like suppose a spasm in an LAD is expected, but spasm in LAD and LCX and even the left main is a rare entity. Second, I would like to highlight that whatever intracoronary vasodilators we give, if a patient has got a complete spasm, they all go into the systemic circulation. So either we could have opted for a microcatheter, and through the microcatheter we could have delivered a intracoronary vasodilator. The third one, it is important for us to think what was the cause of vasospasm. There were three things which we could think about. Either it was the guide-induced vasospasm, which started in the left coronary ostium, spread to LAD and LCX. But as we saw in the angiogram, the spasm started in the distal LAD, close to the lesion, spread to LCX and the left main ostium. The third one, was the radial axis a cause of spasm? Because what we have seen, whenever a radial axis is taken for a PCI, the catheter is not stable. It keeps on jumping in and out of the left coronary ostium. So this could be a reason. The third possibility is this patient might have an element of vasospastic angina. Because as we all know, that prinzmetal angina is also present around the lesions who have atherosclerotic lesions. So this patient was, I would like to tell the follow-up of this patient. This patient was discharged on the 5th day with no complaints other than a broken rib, and he was healthy. But one important point was that a calcium channel blocker was added to this patient's discharge summary, so that keeping in mind the element of vasospastic angina. Thank you very much. Sir, it was EBU 4.0. Yes.